Good morning, dear students. Today our topic is anthrax. Plan of our lecture includes the next issues: worldwide incidence of anthrax, introduction, etiology, epidemiology, pathogenesis, clinical manifestations, laboratory and other examinations, complications, diagnosis with a differential diagnosis, prognosis, treatment, and prevention. On this map, we can see the disturbance of anthrax in the world and hyperendemic and endemic countries shown with red and pink, pink color, and anthrax endemicity for Central, Southeast, and Southeast Asia, for Sub-Saharan Africa, and for Central and South America. So, and on this map, demonstrates that India, Pakistan also include or belong to endemic area. Anthrax in India was published in journal Annals of the National Academy of Medical Science in 2019. So, and these authors demonstrate about the 70 cases of human anthrax were reported in Tamil Nadu, of which 26 cases had cutaneous anthrax, and these cases were registered during the last 2 decades. So, and a review of Indian literature in 1996 found 112 cases of anthrax, and 71 of them was cutaneous anthrax. And these cases were in places other than Bellary. The authors have recorded 23 cases of cutaneous anthrax over a period of 3 years with a single mortality due to septicemia. Recently, outbreaks of cutaneous anthrax have been recorded from Andhra Pradesh in the year 2005, 2009, and 2012, and West Bengal in 2009. This data confirms the epidemicity of anthrax. Besides, in the state of West Bengal, in the and the other 3 southern states of India, that is Andhra Pradesh, Karnataka, and Tamil Nadu. Definition of anthrax, and it demonstrates that anthrax is a zoonotic disease caused by Bacillus anthracis and has 3 forms: cutaneous, inhalation, and gastrointestinal. Mortality rates, if untreated, of 20%, 100, and 25, varies from 25 to 75% respectively. Anthrax caused with Bacillus anthracis. This bacillus has a large size, gram-positive, non-motile rod, and this bacillus has 2 forms: vegetative and spore form. Had a worldwide distribution, and Bacillus anthracis has over 1,200 strains. Within an infected host, spores germinate to produce the vegetative form, which eventually kills the host. These bacilli are released by the dying or dead animals into the environment, usually soil under the carcass. There they sporulate, ready to be taken up to by another animal. Also, vegetative form of Bacillus anthracis grow and multiply readily in normal laboratory nutrients agars or birds. They are more fragile than the vegetative form of the Bacillus species, dying in simple environments such as water or milk. Bacillus anthracis is dependent on sporulation for species, severely making it an obligate pathogen. So, and on the slide, you can see the growth of vegetative form on blood agar, and this culture grows with the white or gray color. Bacillus anthracis life cycle. So, and this sporoform widely distribution in environment. So, when a human infected with this bacillus, so spora entry to the body, and you know about the spora have the high resistance to environment, any factors of environment, to temperature, pH, and another. So, and the structure of spora demonstrate about on the surface. Spora has a exosporium. It's the outermost layer of the spora. Then follow spore coat, very important protein nations permeability layer that has a species-specific composition. Then follow outer membrane. After that, it's a present cortex. It's a fourth number, cortex, and it's a thick modified layer of peptidoglycan that contributes to resistance properties of the spore. After that, the fifth number in a membrane site of germinate receptors, and serve as a major mobility form or layer and sensor of the environment. And in the center the core present, mostly dehydrated center of the spore, containing the genome that it's coordinated with the small acid-soluble spore proteins, calcium, and dipicalinic acid, DPA. So, and into the body, the sporoform has a changes, so germination, outgrowth, and the sensing of germinate molecules triggers the spore to commit to germination. So, and during the germination, this Bacillus anthracis at first, and this step of life cycle of Bacillus anthracis develops into the phagocytes. So, and there is a rapid release of cation and DPA vial. Then number 2, while water is allowed into the core, and cortex, number 3. Cortex lytic enzymes begin to degrade the cortex. Some resistance properties are lost here. So, and during the life cycle, Bacillus anthracis lost this resistance some properties. After that follows the next step, outgrowth, and during outgrowth the cells continue to expand and degrade the cortex and the protein coat. This event most likely occurs in the cytosol of phagocytic cells, And ultimately, the cells must be released from the initial phagocytic vacuole by a currently undefined mechanisms. So, and on the last step, the vegetative growth, vegetative form develops extracellular in lymph nodes, in circulating lymph and blood. Rapid replication occurs systematically. Here the cells acquire nutrients and all remnants of spore structure are now gone through virulence factors, toxin and capsule, and other determinants are produced. So, and Bacillus anthracis produced three exotoxins: protective antigen, edema factor, lethal factor. And protective antigens binds to specific receptors on the cell surface and forms a channel that facilitates the entry of edema and lethal factor. These two agents results in cell swelling and death. Lethal factor is a protease that cleaves specific mutagen-activated protein kinases, blocking cell signal important for neutrophil chemotaxis, macrophage cell survival, and immune cell cytokine production. As a result of host immune system is paralyzes and the bacteria continue to grow rapidly and quickly entering the bloodstream to cause overwhelming bacteremia, shock, and meningitis. So, and the mainly pathogenic factors for this infection, these toxins. And this part of these toxins, protective antigen with lethal factor, it's lead to the lethal activity. Edema factor with protective antigen lead to the edema. And when all these three parts activated and the combination, so it's lead to the edema, necrosis, and lethal. The estimated number of naturally occurring human cases of anthrax in the world is 20 varies from 20,000 to 100,000 per year. Humans are infected through contact with infected animals and their products because of human intervention. Anthrax spores contaminate the ground when an affected animal dies and can live in the soil for many years. Because in the environment, this Bacillus anthracis is present in spore form. Anthrax can also be spread by eating uncooked meat from infected animals. Anthrax is not transmitted from person to person. Human can be exposed but not be infected. So, and in the environment, the spore widely spread, and spores are highly resistant to adverse conditions and are able to survive extreme temperatures, high pH and salinity levels, and disinfectant. So, and animals infected by the injected grazing, browsing, drinking the spore or inhale it sometimes. In other ways, and for transmission of this Bacillus anthracis to animals, it's biting flies. So, and into the body, spore germination and multiplication in lymphatic and spleens, then release the vegetative forms that releases massive numbers of numbers into blood, and it's lead to the death of patients. Lead to the death of animals. And During diet, usually this bacillus, it's affected the lymph nodes and spleen, so and this infected animals has a bleeding. So and during the diet of animals, the vegetative form shed a death in hemorrhage, exudate from the nose, mouth, or anus, or in spilled blood. So, and in environment under the oxygen, so spirulate on exposure to oxygen, and again, it's transformed to sporoform. So, and how the person can infect it with the bacillus anthracis. Also, can infect it by the when bacillus anthracis or sporoform can transmission with a lesion, can lead to the cutaneous form, or biting by the flies. Also, it can lead to the cutaneous form. Gastrointestinal form develops during the if the infected meat or contaminated water, and inhalation, the spore inhalation, so it can lead to the pulmonary form. So, and anthrax spore widely spread in environment, so, and it's an injection. Inhalation inhalation and animals can infect it. So, and the vegetative form, usually vegetative form of bacteria, it's can excreted from the infected animals. Human infected by the biting flies, or injection the infected meat, inhalation maybe, and cutaneous spora can enter through the different lesion or by the that. So the route of transmission of bacillus anthracis. So, and the mortality rate, so depends on clinical form, clinical features, and cutaneous form lead to the mortality in untreated cases in 20%, and inhalation and gastrointestinal forms can lead to the up to the 95%. Pathogenesis. So, spora transmission to human by the different routes. Then after the entries, macrophages involve this bacteria. Phagocytosis develops, and then this bacillus can transformation, so it's a germination, and during the multiply, so this bacillus releases the toxin. You know about 3 parts of toxins: protective antigen, lethal factors, and edema factors. So, and when this toxin release, so it's mainly reason, the pathology reason of in anthrax infection. So, and edema factor mediated an increase in intracellular CMP, which lead to the severe edema in tissues. Lethal factor lead to the tissue necrosis. So, and on the place of entries of this bacteria develops the specific lesion. These macrophages, after the destruction, it's this bacillus then transform to lymph nodes, to bloodstream, and cause a systemic infection. So, and this infection has early stages and systemic stages. So, spora after the germination, no, it's a germination with a release then toxin, and in early stages of infection, edema factor cause the edema through target cells, but it's unknown, and it's shown with the question marks, and it's lead to the edema. Usually the cellular target, not endothelial cells, take place in pathogenesis of anthrax. And both toxins, edema factor and lethal toxins, edema toxin and lethal toxins, disable the innate immune response to allow replication and dissemination of the bacterium to the regional lymph nodes and the bloodstream. In the systemic stage, lethal toxin targets cardiomyocytes and smooth muscle cells, and edema toxin targets the liver to induce can lead to the edema and induce the lethality. So, and when systemic stages develop, so internal organs can infect, so, and it can lead to systemic infection. And in select mice, when a little toxin responsive myeloid cells, and it's activates pro-inflammatory cytokines production, and it's associated with neutrophil recruitment on the place of inflammation, and that is protective against infection, and it can resolution resistance also. So, and it's general of pathogenesis, and it's very important to know the early stages of this infection and systemic. So, and in pathogenesis of this infection, mainly the toxins cause this clinical features of this infection. There are three forms of anthrax: cutaneous anthrax. So, and in these cases, skin effects, and these clinical forms most common occur. Spores enter to skin through the small lesions and cause this ulcer. Inhalation anthrax, in these cases, spores are inhaled and can affect it. The respiratory systems. Gastrointestinal anthrax, spores are injected, and oral, pharyngeal, and abdominal form develops. Cutaneous anthrax. It's occurring in 95% of human cases, and incubation period lasts from 1 up to 5 days after the contact, and the duration of incubation depends on dose of bacillus anthracis, and also it depends on condition of skin. So, and after the incubation period on the skin, the small puritic non-painful pupil develops, and then pupil transformation into the hemorrhagic vesicle, and when vesicle appears, so patient sometimes has them itching, and these vesicles, after that the ruptures of vesicles develops. On this place, slow healing, painless ulcer covered with a black scar surrounded by edema. And for anthrax, for cutaneous anthrax, it's very classical when the ulcer with the black scar develops, and painless, non-painful, because the lethal factor and on this place also affects the nervous endings, and patient usually don't have the pain on this area, and widely edema develops because the edema factors causes widely edema. So, and the infection may spread to lymphatics, and the local adenopathy develops. So, and as a complications, septicemia may develop, and in untreated cases, mortality rate about 20%. So, and prognosis or outcome of infections depends on location of this ulcer. So it can present in any part, in any open part of body, and very, very dangerous when this lesion present on the face or on the head, maybe on the neck, maybe present. So because this infection caused the widely edema, and it can lead to the asphyxia. Gastrointestinal anthrax may follow after the consumption of contaminated, poorly cooked meat. Incubation period of 1 to 7 days. There are two different forms of gastrointestinal anthrax: oral pharyngeal and abdominal. Abdominal anthrax is more common than the oral pharyngeal forms. Oral pharyngeal form results from the deposition and germination of spores in upper gastrointestinal tract. So, and local lymphadenopathy develops an infection of lymph glands and lymph channels. Edema, sepsis develop after the oral or esophageal ulcer. Abdominal form develops from the deposition and germination of spora in the lower gastrointestinal tract, which results in a primarily intestinal lesion. Symptoms such as abdominal pain and vomiting appear within a few days after ingestion. Case fatality at 2 days of infection in untreated cases varies from 25 up to 60%. With antimicrobial therapy, so undefined due to the rarity. Inhalation anthrax. The infection begins with the inhalation of the anthrax spora. Spores need to be less than 5 microns, million of a meter, to reach the alveoles. Into the alveoles, macrophages lyse and destroy some of the spores. Then surveyed spores are transported to lymph nodes. And spores replicates into the lymph nodes. And into the lymph nodes, this bacteria multiply and release the toxin. These lymph nodes in the lungs, the two lungs are separated by a structure called the mediastinum, which contains the heart, trachea, esophagus, and blood vessels. Bacterial toxins released during replication results in mediastinal widening and pleural infusion. On this picture, you can see how affected the mediastinal lymph nodes. And after also it's a scheme of inhalation anthrax, the inhalation of spores, and in alveoles, in lungs tissue, alveoles macrophages involved the spora and dendritic cells. After that, with these macrophages, and it's a transport out of lungs to regional lymph nodes. It's a mediastinal lymph node. Into the lymph nodes, spores then germinate and transform to vegetative form and begin to quickly multiply. This vegetative form grows and toxin production. And also when the phagocytes activate, so cytolysis, anti-inflammatory cytokines can release T or B cells, inhibition of adaptive immunity. And endothelial cells, vascular leakage, hemorrhage may develop. This severe, the systemic extracellular phase of pathogenesis can lead to the final pathophysiology. Inhalation anthrax has two phases in clinical features, and the first phase develops from 1 to 5 days after inhalation of spora, and the patient has symptoms suggest of a viral syndrome, maybe non-productive cough, malaise, fatigue, myalgia, and mild fever. Occasionally, the sensation of chest heaviness is reported. Pharyngitis and rhinitis don't usually accompany inhalation anthrax. It is during this period that spores are being transported by pulmonary macrophages from the lungs parenchyma to the mediastinal lymph nodes. At this stage, antibiotic treatment should prevent progression to the second phase. Second phase. At this time, the spores have germinated in the mediastinal lymph nodes, and protective antigen, lethal factor, and edema factor are being produced by rapidly multiplying anthrax bacilli. Necrosis and hemorrhagic inflammation quickly develop, causing the sudden onset of severe respiratory distress with dyspnea, cyanosis, and diffuse diaphoresis accompanied by fever, tachycardia, and tachypnea. On pulmonary auscultation, moist crepitating rills are evident, and finding consistent with the pleural infusion may be apparent. Chest X-ray demonstrates a widened mediastinum with or out a definite parenchymal infiltrates. Pleural infusion are often also revealed. Inhalation anthrax continued, so death usually results 2 or 3 days after the onset of symptoms. Natural infection is extremely rare. In the USA, was 20 cases were reported of inhalation anthrax in last century. Inhalation anthrax is the most lethal type of anthrax. Incubation period shortly and possibly ranging up to 42 days, depending on how many spores were inhaled. Case fatality after 2 days of infection in untreated 97%, with antimicrobial therapy 75%. X-ray changes, and on the right picture, we can see inhalation anthrax, and widened mediastinum. We can see resulting in less available space for lungs. And for on the left part, we can see the pneumonic plague and the picture of lungs that changes difference. So, and last our lecture we had discussed about plague infection, and we know that alveoles can destroyed as a result of multiply of Yersinia pestis, and it's lead to the infiltration, more massive infiltration. So this infection, pulmonary form of anthrax or inhalation, and pneumonic plague, and by the X-ray also we can differentiate it. The next clinical forms, meningitis. Meningitis and hemorrhagic brain parenchymal infection has been observed in less than 50% of human anthrax cases. Those meningitis must be considered in all cases of systemic anthrax, and antimicrobial drugs used to treat possible meningitis must have good penetration of the central nervous system. The clinical features of meningitis include severe headache, altered mental status, meningeal signs, and other neurological symptoms and signs may also present. And on this picture, you can see the brain of person who died from inhalation anthrax. Differential diagnosis of cutaneous anthrax, because it's more often occur. So, and it needs to be differentiated from vaccinia, Milker's nodule of Echema contagiosum and furuncle. Painless is hard with a profound edema, and lack of neutrophilic response gives clue to the diagnosis of cutaneous anthrax, supplemented by gram strains, smear, and culture of Bacillus anthrax. The anthraxine skin test, consisting of subdermal injection of a commercially produced chemical extract of an attenuated strain of Bacillus anthracis, is now available for the diagnosis of acute and previous cases of anthrax. How is anthrax diagnosed? Gram strain, and culture of Bacillus anthracis from blood, skin lesion, vesicular fluids, or respiratory secretion. It's a gold standard for diagnosis, for confirmation of anthrax. X-ray and computer tomographies can also informative, because we know the classic characteristics of X-ray changes. Rapid detection methods also can use for diagnosis: PCR for detection of nucleic acid, ELISA for antigen detection, other immunohistochemical and immunofluorescence examination. These are available only at certain labs. So, in the culture lab test for anthrax, so I used the nutrient medium, and on these cases, the blood agar, and on blood agar, Bacillus anthracis grows of large gram-positive bacillus. Treatment. For treatment of anthrax, we use ciprofloxacin, maybe in other fluoroquinolone, because they inhibits DNA synthesis. And second group of antimicrobial doxycycline. Doxycycline or tetracycline group of drugs, they inhibit protein synthesis. So, and for cutaneous anthrax, without the systemic involvement, we can use oral form of drug ciprofloxacin, 500 milligram every 12 hours, or doxycycline, 100 milligram every 12 hours. Levofloxacin, 750 milligram every 24 hours, so it means one time a day, or moxifloxacin, 400 milligram every 24 hours also. Clindamycin, 600 milligram every 8 hours, or alternative for penicillin susceptible strains, amoxicillin, 1 gram every 8 hours. So, and alternative may be penicillin, 500 milligram every 6 hours. Duration of treatment is 7 or 10 days for naturally acquired cases. In systemic anthrax, when meningitis has been excluded, so, and intravenous therapy used, antibacterial. Ciprofloxacin, 400 milligram every 8 hours, or levofloxacin, 750 milligram every 24 hours, or moxifloxacin, 400 milligram every 24 hours. So, or meropenem also may use 2 gram every 8 hours, or imipenem, 1 gram every 6 hours. So, the drug of choice is a ciprofloxacin. So, if fluoroquinolone has a non-effective, or patient has an contraindicated for use this drug, so in these cases may use the meropenem or vancomycin maybe. So, and alternative for penicillin susceptible strains, penicillin G, 4 million units every 4 hours. Ampicillin 3 gram every 6 hours, plus protein synthesis inhibitor, clindamycin or linezolid maybe that. So, and may combination with doxycycline, this ampicillin. So, and duration of treatment for 2 weeks until clinical criteria for stability are met. So, and antibiotics treatment of bioterror bacterial agents. In these cases, for prophylaxis, the first line of antibiotics, ciprofloxacin, or levofloxacin maybe so, or doxycycline. And duration 60 days, also for cutaneous formed cutaneous disease, only when this infection can confirm as a as a weapon, maybe confirmed. So for treatment, ciprofloxacin or doxycycline first line also used 60 days, and for treatment used intravenosis, and maybe inhalation form, maybe gastrointestinal or meningitis. Prevention of this infection depends on prevention of animal anthrax, as has largely been achieved in Europe and in the United States. Humans are protected by public awareness program regarding the dangers of contact with the infected animals or their meat and in other products. Vaccines have been developed for human use. Who gets vaccine? People who work directly with it in the lab, people who work with imported animals' hides or furs in area where standards are insufficient to prevent exposure to anthrax spores, people who handle potentially infected human or animal products in high incidence area, and military personnel deployed to area with high risk for exposure to the organism. And in these cases, the biotrax anthrax vaccine, it's used subcutaneously, 0.5 milligrams, pre-exposure prophylaxis intramuscular, and primary for pre-exposure, primary 0, 1, and 6 months, and booster series. So it's additionally it's necessary also used 6 and 12 months after completion of the primary series, and at 12 months intervals thereafter. Post-exposure prophylaxis, subcutaneous primarily series, so 0, 2, and 4 weeks post-exposure combined with antimicrobial therapy. And contraindications for vaccine: do not admit biotrops to individuals with a history of anaphylactic or anaphylactic-like reaction following a previous dose of biotrops or any component of the vaccine, including aluminum, benzethonium chloride, and formaldehyde. So thank you for your attention.